See, the topic of cardiac stun on ECMO dates back as old as 1990, when the world was trying to solve the mystery of sudden increase in heart failure population and all those trials like consensus and salt and other things were trying to understand the pathophysiology of heart failure. Then many new terminologies were coined like acute heart failure, myocardial stunning, uh, cardiac hibernation, cardiac stasis, and all those things. So the same thing gets applied whenever there is an acute insult or a sudden increase in the stress on the heart. So this is an interchangeable word. In fact, cardiac stunning is a very small component in the entire spectrum of cardiac insult on ECMO, the patient on ECMO. So I will try to discuss. There are many terminologies like LV dilatation, LV distension, LV stasis, cardiac stunning, and etc. etc. So I will try to solve all these things and put them in a proper order, that what happens one after the another and what is the mechanism behind it. There are no financial supports. As you see over the years in 2016, where there was hardly 75,000 cases of total ECMO runs across the globe, and the cardiac ECMO was something around 8,000 or 9,000 with a survival rate of 40%, to 2021, the number of cases has almost multiplied 2.5 times, with more than 1 lakh patients have been on a cardiac ECMO with the percentage of survival remains the same, but the volume of work has increased. So, with that, our experience and understanding of the disease has increased. As you see, the annual cardiac runs in pediatric population and adult population has dramatically increased from 2010 onwards. And then you can see from 2010 to 2021, you find around 6,000 annual runs of cardiac cases have been documented, and then a steep rise after 2015. So our knowledge has also increased proportionately. Now, what is a cardiac support for ECMO? The cardiac support for ECMO, the VA ECMO, what does it do? It gives myocardial rest. It causes it relieves the pulmonary venous congestion, and it is helpful in relieving the pulmonary hypertension. That is what a VA ECMO would do to the heart. Now, what is the pathophysiology behind cardiac stunning? I will come to the terminologies later on, but first, the topic was cardiac stunning, and I had to understand the uh, pathophysiology of cardiac stunning. The normal physiology in a normal subject is like this: there's a pulmonary circulation, there's a systemic circulation, both are connected in series, and the blood flows in a sequential manner from RA to RV, then LA to LV, crossing the lungs. And this is the pathophysiology in a VA ECMO. This VA ECMO shows that the blood is diverted from the RA to the ECMO circuit, and it goes to the systemic circulation and returns back to the ECMO circuit. The entire components of the thorax, the right ventricle, the lungs, the left atrium, and the left ventricle, they are totally parched. This is the main pathophysiology behind all this cardiac insult we are talking about. This is totally unphysiological. Whatever VA ECMO we talk about is a cardiopulmonary bypass circuit. It is not a VA ECMO circuit. We have used the same concept of bypassing the lungs and the heart, but lungs, that was for a open heart surgery where you had to operate upon the heart and open up the heart. We are using the same circuit. We are again drying the entire intrathoracic component, and from there a series of cascade of metabolic, biochemical, neurological interaction starts, which is responsible for many of the pathophysiology behind cardiac stunning and LV stasis. So I would like to show you a video. This is a patient of myocarditis. This is day 1. The patient had a hemodynamic crash. The patient was put on ECMO. You see a comparatively good cardiac contractility. This is day 1. Now day 2. Can you see the heart? Is the heart distended? No, the heart is not distended. The patient is a young patient, and you see the cardiac contractility, day 2. What ejection fraction appeared 40% is 20% now, day 2. Could you appreciate? These are the complete echo pictures of the patient on day 2. Third day, the ejection fraction is 10%. Nothing is moving in the heart. Also see the heart is not dilated, distended, nothing. Just the heart had reduced contractility. Day 4, slight improvement. Some regional wall is seen here, but contractility is improved to 25%. Subsequently, the patient improved. Okay, so cardiac stunning is a multifactorial causation by immunological mechanism or biochemical reaction or hormonal effect or neurohumoral effects which causes a decreased contractility. Now, it can be similarly compared to a condition like myocardial stunning of myocardial infarction or hibernating myocardium, where the chances of reversibility is there. So, the dividing line between cardiac stunning and LV stasis is between reversibility and irreversibility. Also, in cardiac stunning, there are many body related uh, biochemical mechanism working which causes a decrease leading to myofibrillar edema, which causes a decreased contractility, but all left ventricular distension, dilatation, and stasis are all mechanical complications which are as a result of overstretching because of a non-contractile LV and a blood remaining standing because of a closed aortic valve or severe mitral regurg or severe pH, whatever. So, therefore, stunning is a reversible condition, which is a disproportionate reaction, which comes very soon and it is reversible and exact uh, fate whether this stunning is going to land into stasis or other thing will depend from patient to patient. It may totally reverse in myocarditis or arrhythmias, and it may not reverse in other conditions like where there is a severe insult to the heart like myocardial infarction. So basically the incidence of cardiac stunning is between 1% to 6%. It is diagnosed by a flat arterial tracing with a pulse pressure of less than 10. The 2D echo shows a poor LV contractility with generalized hypokinesia. Other mechanisms of pathophysiology behind cardiac stunning is myocardial hypoxia, hyperkalemia, hypocalcemia, reperfusion injury, primary pulmonary hypertension, and acute increase in afterload. And you have to treat the condition as they arise and as you diagnose them. So, how do you manage cardiac stunning? We have to go slow on the pump, we have to decrease the flow, we have to start inodilators like milrinone, adrenaline, and dobutamine, and give calcium gluconate. As I was telling, the topic of cardiac stunning is short, but when applied to VA ECMO, I would extend this cardiac stunning beyond to VA ECMO. And we have got terminologies like myocardial stunning, myocardial hibernating. And when the ECMO is there, decreased cardiac contractility is cardiac stunning. These lines marked in red are reversible conditions, and they are reversible because of many mechanisms like hypoxia, catecholamines, SIRS, myocarditis, chemomyonecrosis, tachycardiomyopathy, hypotension, and hormones. So these conditions are reversible. But in VA ECMO, after a time period, the same cardiac stunning goes to LV distension, dilatation, LV stasis, left atrial hypertension, pulmonary edema, and intracardiac clots, which require a surgical intervention. You have to go for venting or evacuation of clots, other things. So this part of VA ECMO would require a mechanical intervention. So what are the difference between myocardial stunning or say cardiac stunning versus LV stasis? Myocardial stunning is transient and left ventricular distension and dilatation requires treatment because of a closed aortic valve or severe MR or raised LVDP or increased bronchial circulations, etc. Then this distension and dilatation will lead to all those things: stasis, left atrial hypertension, pulmonary edema, LV clot, which would require an LV venting. As I was telling yesterday also, before the thing start, proactively, if you start doing something for LV stasis here, you will not have to face the music of all these things. So, uh, if possible, try to prepare the patient or keep it a place ready for LV venting to prevent first insult to the heart and then partial recovery. So I will come to that point later on. Decreased LV contractility, as you said, is like same thing as cardiac stunning and may not require a mechanical treatment, but you can help this cardiac stunning with decreased preload, altered and improving the coronary perfusion, decreasing the afterload, and they have shown that with regard to the workload on the heart or increased left ventricular wall stress, this cardiac stunning is not directly related. It has got a chemical mechanism inside the myofibrils. So even doing all these things may not help in cardiac stunning. It is a time-dependent mechanism which would improve. And the only way to establish is on a repeated echo assessment. What does a VA ECMO does? It decreases the preload, it increases the afterload, it increases the systemic blood flow, it decreases the pulmonary blood flow. There's a differential circulation hypoxemia and a left heart stasis. So all this ECMO in fact is a very bad machine for a failing heart. If you talk of other mechanical circulatory supports or LVAD, when you see the hemodynamic mechanisms, they do wonders. Therefore, the ECMO has not yet picked up for heart failure, as I will come to this topic later on. But if you say ECMO, the basic mechanism of increasing the afterload, increasing the left ventricular wall stress tension, decreasing the coronary circulation, have got a much detrimental effect on the heart per se. What will you do for left heart stasis? It will require mechanical treatment. You have to look for left heart thrombosis, pulmonary edema. You have to try to solve the left ventricular wall tension and improve the coronary circulation. This I was telling the harmful effect of left ventricular distension. So read this line. After the patient has left ventricular distension, even if the patient is improved, the left ventricular performance remains significantly depressed. This injury can occur clinically in a non-vented heart, and this will persist for a long time and will result in a poor LV ejection fraction later on. So, first allowing it to happen and trying it to cure will also kill the heart by 50%. So, you have to treat this left ventricular distension proactively so that it does not happen at all. Now, after cardiac stenting, as I said, the second phase is left ventricular dilatation. This left ventricular dilation is caused by the residual venous return from the collaterals of bronchial and pulmonary artery, severe left ventricular distension due to high afterload because of mitral regurgitation, failure of aortic valve to open or aortic valve insufficiency, and it is reported between 12 to 68% of VA ECMO patients. This you can see the starting of left ventricular dilatation. Then dilatation leads to distension. Distension is contributed by RV dysfunction, pulmonary edema, deoxygenated blood, left atrial hypertension, myocardial stenting, inadequate coronary perfusion, LA-LV clots, increase afterload, decrease cardiac output, and disruption of aortic laminar flow. This disruption of aortic laminar flow is a complete different topic in itself. As soon as the mean arterial pressure in the aorta decreases less than 70, many of the chemoreceptors and baroreceptors get activated, and they cause a great damaging effects on the myocardium because of activation of many pathways. So now the left ventricular distension, you have to try to solve it by maintaining the aortic pulsality. You have to diagnose it proactively, and you have to facilitate the left ventricular ejection fraction by IABP, inotropes, minimize the vasoconstrictors, and reduce the ECMO flow. If all that is not working, you have to think of LV venting. LV venting has various types of modalities. You can do a transthoracic LV venti, that is, your patient is a post-cardiotomy patient, or percutaneous atrial septostomy, or mechanical circulatory support devices like tandem heart and impella. Now, further down the line after left ventricular distension is left heart stasis. Consequences are all same, as the pathophysiology is the same. As it persists for a longer time, the heart keeps on sinking. Treatment is left heart decompression, increase inotropes, decrease afterload, increase preload. Management, improve the coronary circulation by an axillary artery cannulation, unload the left ventricle by IBP, atrial septostomy, LA vent, or LV vent. Then further down the line after LV distension and left heart stasis is a reverse pressure. You get left atrial hypertension and pulmonary edema. So again, the causes are the same, pathophysiology is the same in all the things, only the persistence of these factors leads to a cascade. Then you see if there's a left atrial hypertension, the pulmonary the pulmonary plethora and pulmonary edema you can see. Anyway, when the pulmonary artery pressure is more than 820, you can expect pulmonary edema. These are the various pictures of serial changes in the X-ray as the patient persisted in cardiac stenting and left ventricular stasis. This is day 1, day 2, day 17, day 19. So, how do you treat left heart stasis or pulmonary edema? You create an atrial septostomy, cause pulmonary and tricuspid valve insufficiency, use a mechanical circulatory support with LVAD or maybe impella or tandem heart, cannulate the left atrium or cannulate the pulmonary artery. This is one of the mechanisms of balloon atrial septostomy to create an right to left shunt across the interatrial septum, thereby in an attempt to decompress the LA pressures. Venting options are atrial septostomy, balloon, blade, and radiofrequency. Right superior vein, pulmonary venous vein venting, that is done post surgery, or a venting cannula by percutaneous method or invasive method. Then management of pulmonary edema under peripheral V ECMO, the increase the because it is caused because of an increased LV afterload. So the solution is dobutamine, decrease the ECMO flow, use an intra-aortic balloon pump, do atrial septostomy, do a transseptal LA drainage, or use Impella, or switch over from femoral to central VA ECMO. This is the picture to show you the coronary artery flow as the left ventricular wall tension increases. So the coronary blood flow decreases significantly. This is the echocardiography mechanism to assess the left ventricular functions, made by the ejection fraction calculation, the mitral valve E by E dash, tissue Doppler studies, or the TDSA on the tricuspid valve, and the aortic VTI, the velocity time integral. You can see all these pictures of this the echo parameters have very well shown. The patient could be weaned off or could not be weaned off by using the previous parameters I told you. These are all echocardiographic images. Now, VA ECMO, after a left ventricular stasis, is a thrombus. You can see a LA thrombus. You can see an LV thrombus. This is aortic root thrombus. So, what is the solution? The solution for ECMO is convert the patient from VA ECMO to VVA ECMO or VAV ECMO. Other hybrid circuits that can be used to tackle left ventricular stasis is VAA, VAV, VAVA, or VVA. This is about ECMO. Then, from the history, what has been used and what has been discarded to tackle cardiac stenting was the smart cannula. The smart cannula is an sort of an auto-adjustable elastic device which used to go from IVC to RA to RV across the tricuspid valve, then across the pulmonary valve into the pulmonary arteries. So this is the device. It looks like this, and it stretches itself to the diameter of to the margins of the chamber, and it used to go all the way from IVC, tricuspid valve, pulmonary valve into the pulmonary artery. This was the course, and this was the effect. There was a severe TR and a severe PR. So all the pulmonary artery blood used to come back to the IVC without interruption, thereby decreasing the pulmonary artery pressures. But it did not help much. So now it is not much in use. Then other temporary circulatory supports commonly known are ECMO, tandem heart, and Impella. Patient on ECMO developing cardiac stenting or LV stasis has to be tackled with tandem heart or Impella, but they are way costly. So again, we are unable to use them freely. Then other thing has been on ECMO itself to use ECMO as a LVAD using a centrifugal pump. So these are the centrifugal pump, which is a partial VAD or a mini VAD. So they are the other mechanism. Simple things like a pigtail catheter during an VA ECMO can help to create wonders. You can see this was the previous picture, and this is using a pigtail catheter, and you can see the effect on entire pulmonary edema cleared. But it would require at least 8 French or plus pigtail, which is not readily available. 7 French will hardly drain 700 cc per minute, which will be less. Other devices on mechanically circulatory support are IBP, the ECMO, the Impella, the tandem heart, the Levitronic centrifugal machine, and ventricular assist devices. These are the various picture of various devices which can be used in cases of cardiac stenting and left ventricular stasis. They are into various category. These are intracorporeal and these are extracorporeal. These are pulsatile, axial flow, and centrifugal flow. And these are continuous flow pumps divided into all these categories. Commonly used are impella and tandem heart. In impella, we use it like making an femoral artery puncture, and the catheter advances all the way through till it crosses the aortic valve, and there's a pump inside this 12 French catheter which sucks the blood from the left ventricle and pushes it into the aorta. In tandem heart, it is a mini ECMO. We don't have to use the oxygenator. The circuit is very small. We go by the IVC to the right atrium, puncture the intraatrial septum, and place the catheter into the left atrium. So left atrial blood is sucked, which is already oxygenated, and can be directly introduced back into a femoral artery. That is tandem heart. Then centrimac devices, these are the components. Then impeller devices, these are the components. Then people have shown the result of LV decompression, that using another device which is not very popular, that is novel pulsatile paracorporeal assist device, but it also has shown a very good result. Then tandem heart, these are the components. Okay, then these are tandem heart. Then the comparison between all these assist devices. So IBP, VA ECMO, tandem heart, impella, and the centrimac. Then various components on the positive and negative points. But if you look at VA ECMO, it I'll show. The hemodynamic support is great, and rest all the things are okay. But what you have to see here, this is the afterload is increased here in VA ECMO, whereas it is not affected or neutral or reduced in other devices. Then the tissue perfusion in VA ECMO is improved, but in and greatly improves in other things. But these may be only the peripheral signs. Let me come down to the pressure volume loops, where I will tell you the comparison between the two devices. So you look at this picture. This is a normal cardiac curve, and this is what happens in myocardial infarction. That the normal gets. This is for the normal curve, and in myocardial infarction, there's a shift to the right. In cardiogenic shock, the further shift to the right. What a ECMO does, if this was the picture of a cardiac insult, the ECMO further increases the curve right and left. It does not shift it to the right at all. Where the LVAD, peripheral LVAD, would shift the curve significantly to the right, so to the left, and IBP also does not do much. So if you have got ECMO and IBP for at our disposable, both are not very great devices. This is just to show you this black line is a normal curve, cardiogenic shock is a red line, ECMO is the green line, which is further deteriorating the cardiac index, and impella is the blue line, which is improving it slightly. The same thing in tandem heart, there's a shift to the left. In impella, there's a shift to the left. In VA ECMO, it is increasing the wall stress, and there's no shift in the cardiac pressure volume loop. And IIBP also, it is redistribution but no shift. So the work is done by tandem and impella to unload the heart, not by VA ECMO. The same thing being told. And IIBP work at around 1 liter cardiac support. ECMO works from 3 liters to 7 liter cardiac support. Impella works between 2 liters to 4 liter in all this range. So ECMO has its advantage. It is a biventricular support. One, it has a great role to play in decreasing the pulmonary congestion. Two, and it can be modified. The circuit can be modified. It is in a fluid state. Three, these are the three great advantages of VA ECMO. But the disadvantages of VA ECMO are that it has a very deleterious effect on the left ventricular cavity and the left ventricular wall tension. So it leads to left ventricular stasis. And you have to supplement ECMO with some additional device to rescue the heart from this side effect of applying a VA ECMO. So the conclusion or take-home message is that ECMO allows resuscitation of the patient of shock. Complication unique to ECMO should be anticipated and avoided. The survival rate is between 25% to 40%, and the long-term survival are ECMO. In fact, VA ECMO for a cardiac patient is a short ECMO. You will have the answers in 1 week. It is not like a respiratory case. For 1 month to 2 months you have to wait. So you know whether you have to abort the exercise or there is a destination for the patient. But the answers are clear in 1 week. So one more thing. Important part of the message is that if this is the cascade of the various condition of the heart and whatever we are doing pharmacologically or mechanically, the ECMO is considered at NYHA class 3. If we can decrease the time period and start applying ECMO in NYHA class 2, then perhaps the story of success by ECMO on a failing heart would be different. Thank you.